the chair of Campbell and Cochrane Economic Methods Group and president-elect International Society for Pharmacoeconomics and Outcome-Based Research in India. Additionally, he served as an advisory group member of the Disability Coordinating Group, Campbell Collaboration. He served as an associate editor for Systemic Review, Cost Effectiveness and Resource Allocation, and for BMC Public Health Journals. He's listed as a top 2% most cited author in public health as per Stanford's 2022 list. He has published over 25 evidence synthesis publication, systematic review, scoping reviews, and evidence and gap maps. We are welcome, Prof. Thank you so much.
Thank you. I am sharing my screen and thank you for the invitation for attending. I hope I'm audible to everybody.
Yes, Prof, we can hear you. Thank
Okay.
you.
Thank you. Thank you. Good afternoon from India. To those who are in the South African continent, we are a little bit. My job is to give a small background for all the attendees on what JBI Institute is all about and a small detail of some of the activities that JBI is introducing. So JBI is a global organization, and the objective of JBI, you notice that there's a small logo, is to provide evidence-based decisions or support and promote evidence-based decisions that improve health and health services. And what JBI does is it provides a unique range of solutions in terms of how to access data, how to appraise the evidence, and also apply the best available evidence. And it's basically drives through major objective is to drive and improve health outcomes in communities. And the way that JBI responds is by using very high quality, reliable information and using very focused evidence-based resources, software such as Sumari. The JBI has a JBI Sumari software. It has got education in terms of courses, but also it does both focused and general trainings for improving the understanding of systematic reviews, scoping reviews, and other such products, including evidence implementation and clinical guidelines as part of its training component. So this is the background in which JBI has. But I think any particular entity has a history, and I think it is important for some of us to understand that. JBI was established as a research institute in 1996 in the Royal Adelaide Hospital in South Australia, founded by Professor Alan Pearson, and it was named after, if you see the photograph on the bottom right, is after the Joanna Briggs, who was the first matron of Royal Adelaide Hospital in 1855. And JBI was established with a grant from the Royal Adelaide Hospital Research Foundation. And from 2010, JBI became part of the Faculty of Health and Medical Sciences at the University of Adelaide. So JBI, since its formation, went into two kinds of revisions. This is the second revision that I'm presenting here, which is the JBI model of evidence-based healthcare. And the way that JBI looks at evidence-based healthcare is in the feasibility, appropriateness, meaningfulness, and effectiveness of healthcare practice. So if you notice this, the figure on the left side, it has got inner segment, which is around a red colored dot, which is focused on evidence-based healthcare. So you have four components there, which is global health, evidence generation, evidence synthesis, evidence transfer, and evidence implementation. And then you have an outer circle, which is more about so these are the inner segments are actually the conceptualization of the steps involved in various processes, and the outer segments highlight the operational part of the component part of the proposal of the model and how they can be actioned in a pragmatic way. And the JBI model of evidence-based healthcare has four overarching principles. culture, capacity. On this, if you go into the the specifics, the red dot that you saw in the previous one, which is called as the pebble of knowledge, and the knowledge looks at four components: that any evidence of an intervention should be feasible, which basically should be the extent at which any activity or an intervention is practical or viable, including cost effectiveness. It should be appropriate so that it can be fit into a particular context or a situation. It should be meaningful. There has to be a meaningful component so that it is the intervention can be experienced by an activity or by the means that they prescribe. And finally, it has to be effective. So the effectiveness, the extent at which the intervention achieves the intended result or outcome. So the pebble of knowledge, which has got four the broad components: feasibility, appropriateness, meaningfulness, and effectiveness, forms the pebble of knowledge of the JBI's model for evidence-based healthcare. Now, taking each of the specific components, the first one being global health. And the reason that JBI started with this global health is because of the need for health being more global. While some people use public health, JBI picked up the component of having global health with where the three aspects are focused more on sustainable impact, engagement, and knowledge need. So these are the three, as I mentioned from the previous one, the global health is the inner, but these are the three elements of operationalizing in as far as the evidence is concerned within the JBI evidence-based model. The second one focuses on evidence generation and which focus on three broad areas: research, expertise, and discourse. And evidence generation. Evidence generation is basically, we need to be, the evidence-based generation is defined through well-designed research studies, which are grounded by any methodological position, anecdotes or opinion and experience. So the evidence generation relies on methodological backgrounds, and you'll notice that JBI comes with guidelines focusing on scoping reviews, systematic reviews, clinical guidelines, and evidence implementation. And that has based on a method. So there are JBI methodological positions around these areas, which guides the evidence generation for a lot of the elements that come from JBI evidence synthesis kind of products. Uh, Evidence synthesis is the third element, which is focusing on guidelines, evidence summary, and systematic reviews. Please ignore that's an error from my side for the left explanation. But just to give a guideline that for JBI, the methodology of systematic review is focused on all types of reviews. It could be systematic review, it could be scoping review. But systematic review and scoping review tend to take a long time because of the methodological requirement of conducting such reviews. And hence, JBI is also promoting or suggesting the need for evidence summaries. And COVID has taught us that in most of the cases, in public health emergencies, evidence summaries are more practical because of the timeliness, provision, availability of such evidence compared to a systematic or a scoping review, which takes a little bit of time. And then the final one is that the evidence can go to guidelines, and these guidelines are again guided by the JBI methods. Methodological aspects are being considered. And so these are the three elements which constitute the evidence synthesis component of the JBI's model for evidence-based healthcare. The fourth element is the evidence transfer, which is basically again the way that JBI focuses is through education, systems integration, and active dissemination. The evidence transfer is through both formal and informal means of education. My education, I mean here, is mostly like not only educating the generation of method researchers who are conversant with the evidence synthesis methods, but also educating the public in terms of users such as clinicians using the evidence based methods, but also public at large. You need systems integration to ensure that these kind of aspects are taken together, and then you have to focus on an active dissemination of this evidence. So this is how JBI uses the evidence transfer mechanism across these three components. And finally comes the evidence implementation. Again, evidence implementation focus on three areas: context analysis, facilitation of change, and finally evaluation of process and outcomes. So evidence implementation is where you do content analysis, context analysis to ensure that whatever the evidence is available, how much is it context relevant, what are the facilitators of change in those contexts where the implementation is being considered, and finally, how do we evaluate the process and the outcome. So evidence implementation is one of the important areas that are focused with the newly designed implementation aspects of JBI. Now, JBI is also having a collaboration. While the JBI entity in Adelaide focuses on the main body, but there are many institutions across the world which form the family of JBI collaboration entities. And these collaborative entities are structured around two groups, one called as JBI Centers for Excellence, and the other is called the JBI affiliated groups. So, for example, the JBI Kolkata, the Center for Public Health Research, and JBI in South Africa are both currently JBI affiliate groups. That is how people enter into the JBI family. And then those groups which have matured with delivery of various systematic review trainings and products move towards being center for excellence. So that's the hierarchical way of promotion of these centers towards being center for excellence. The objective of these JBI collaborating centers is to drive the worldwide effort towards support and promotion of the use of best available evidence, but also towards ensuring that local clinicians and consumers around that global collaborating entity lead evidence-based initiatives in that region's country, state, or specialty. So, for example, the JBI Center for Public Health Research is based in Eastern India, Kolkata, India, where we are the only center in this part of the world of the country. And we are hoping that our newly formed center from last 3 months will try to ensure that evidence-based initiatives get more entry, more equipped in this part of the world, but also to ensure that the country benefits from such evidences, including focusing on different areas. Finally, a bit about our center, just to ensure that we all are aware of it. Our center in JBI Kolkata is known called as the Evidence Synthesis and Implementation for Indigenous Health. And the reason that we focused was that Center for Public Health Research is part of the parent organization of Month, which has been working in indigenous population in India, in West Bengal for the last 60 years. But the center, because not only of that expertise, but also the need that these indigenous population of India has specific health needs. They are marginalized. They have specific customs, cultures, healthcare, unique healthcare needs, and hence suffer from a very quadruple burden of diseases. And while focusing on intersectionality, equity, evidence synthesis, and implementation, we are aiming to use that this center works to generate the necessary evidence to bridge the gaps between indigenous and non-indigenous population. So we are a team of 4 or 5 people where we focus between indigenous evidence synthesis and implementation. However, we broadly have 3 broad areas of activities: collaborating with faculty research groups to provide methodological inputs for research programs. So, collaborating with clinical and public health practitioners on how to tackle clinical and public health priorities through both evidence synthesis and evidence implementation. And finally, by delivering high quality evidence synthesis screening and evidence based healthcare. Yeah, so that's it from my side. I'll be happy to answer any questions and response. Thank you.
Thank you so much, Prof, for the welcoming and for also giving us the JBI. What is JBI all about? The JBI talk to the issue of evidence-based practice that need to improve clinical management of patient, clinical management of research, evidence-based healthcare, and serve as a synchronizing collaboration and widely accessible interregional a space to promote evidence-based practice, discussion, and debate. Thank you so much, Dr. Prof, for your words. Thank you, Prof. I think let's continue with the first session of today's interactive building partnership for evidence-based practice for adolescent health in South Africa and India. The next on the speaker is Dr. Ben Mundwedi from South Africa. Dr. Ben Mundwedi is a clinical manager of the HIV and TB program at the Ekurhuleni Health District. He holds an MBSHB and a Bachelor of Dental Therapy degree. His key role involved capacity building of clinicians and non-clinicians on HIV and TB guidelines from the National Department of Health and clinical support of complicated patients from HIV and TB comorbidities. Dr. Mundwedi will be chairing our first session with Dr. Nimala Mukheri from India. Dr. Nimala Mukheri, India, has been serving as the director of Manbat Ananda Ashmar Nichanda Trust since 2003. He has also been acting as head of the Center for Public Health Research Wing of MANT, and a JBI affiliate center. He's trained and professional social worker. He has a master's public health and a PhD mass communication and journalism. He has attended several short executive courses from prestigious institutions, universities like Johns Hopkins University and the University of Pennsylvania. He has more than 23 years of experience in conceiving, designing, managing, and evaluating health and development projects in various capabilities. You are welcome, Dr. Mundwedi and Dr. Milaya. Over to you, Dr. Mundwedi.
Good day, colleagues, and thank you so much for the invitation. And thanks so much to Sister Mpoma Klabadira, and good thanks as well to the organizers, the JBI group, both in South Africa and India. I'll be co-chairing this second session with Dr. Nimala Mukheri, who's already been introduced. And I think we'll be discussing the issues of adolescent health in both India and South Africa. And just a reminder to all of us, WHO talks of health, as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. It will be interesting to find out whether, the definition of adolescent, in terms of age group, is the same both in South Africa and India and the world over. To that, I wish then to introduce our first speaker, who will be talking to adolescent health. I'll be chairing the two sessions, and then my co-chair will be chairing the last two sessions. I'm introducing the first speaker who's going to talk about adolescent health, the challenges in adolescent health, who's Dr. Gwen Ramokgopa. Dr. Gwen Ramokgopa in South Africa, she's a special advisor to the Minister in the Presidency in South Africa. She's also the Chancellor at Tshwane University of Technology and an associate to the World Health Organization Collaborating Center on Social Determinants of Health at the University of Pretoria. She holds an MPhD and a master's degrees in public health. She's also a board member of the South African Medical and Dental Practitioners Association, the Medical Women of South Africa, and the Medical Cooperative Bank. She has served in various government positions as chairperson of the executive in the City of Council of Pretoria, the executive mayor of the City of Tshwane, provincial member of the Executive Council for Health and Social Development, and also National Deputy Minister for Health in South Africa. And she's also been holding university positions as the Councils of Medical University of South Africa and the University of Pretoria. Dr. Gwen Ramokgopa will be joining us from China, and we will be assisting her in terms of sharing of slides. Over to you, Dr. Gwen Ramokgopa. Thank you.
Ma'am, you are not audible.
Yes, I was just thanking the program directors for this opportunity to share some few thoughts about adolescents' health in South Africa, and indeed also to learn from your good selves from the various settings, especially in terms of evidence-based solutions. I really believe that evidence-based policy, evidence-based practice, and translation are key in advancing health overall, and in particular, in this case, adolescents' health. Next slide. Okay, am I able to move my slides? Oh yes, I think I can move my slides. No, the next slide, please. Thank you. Evidence-based implementation is also recommended by the community of health under the leadership of the World Health Organization. And indeed, it is important to look at the various issues that I'll be covering, which is on global standards. I'll zoom into the South African policies and guidelines that are there, and looking at the health indicators and underlying factors, as well as challenges and opportunities, and a few recommendations to share with you. Thank you. On global standards for quality healthcare services for adolescents, these are the key areas that of focus in terms of access by adolescents to quality healthcare services, and for healthcare services as well to be responsive to adolescents. An important issue is adolescents' health literacy. We do have a number of studies that shows that just the understanding of the need to go to a healthcare service provider requires that we guide the adolescents to understand that. The issue of community support, very important. We've experienced that in issues of unplanned pregnancies, issues of also planned pregnancies as well, and prevention of unplanned pregnancies, that there's a need for services to be more appropriate for young people so that they can use them and access them when they need them. Appropriate packages of services are also key. Providers' competencies to understand the needs of a young person and the perspectives of young persons. And that's why peer support in most cases does work better. Facility characteristics, young people may also be sensitive in open settings where it would be obvious that they're going into a room that is already there, marked termination of pregnancy or something like that. So facility characteristics is also very important. Equity and non-discrimination, which is self-explanatory. Data and quality improvement, very important, so that we can respond to the issues that indeed are pertinent as part of the evidence-based solutions. And as I've indicated, peer support and adolescent participation for them to express themselves in a manner that we are able to respond to their needs appropriately is key. Adolescents' health globally, this is from WHO, that over 1.5 million adolescents and young adults aged between 10 and 20 years died in 2021, almost 4,500 daily. And that young adolescents aged between 10 and 14 years have the lowest risk of death amongst all ages. There's an opportunity there as well for us to sustain, and that injuries, including road traffic injuries and drowning, interpersonal violence, self-harm, including also suicide, maternal conditions, are the leading causes of death among adolescents and young adults. And half of all mental health disorders in adulthood start by the age of 14, but most cases are undetected and untreated. Early onset of substance use is also a key challenge there. And globally, there were 42 births per 1,000 to girls aged 15 and 19 years in 2021. South Africa is also, experiencing some of these challenges that bedevil young people all over the world. And just to zoom into the context of the South African health system, the Constitution presents a Bill of Rights that also identifies health as well as reproductive health as a right for all citizens. And therefore, the right to health for adolescents is quite critical, but it is also a constitutional right. National Health Act also reflects on this. The National Health Insurance Bill, which is in Parliament, the federal structures in our country also have incorporated the health needs of adolescents. These are the 9 provinces, 52 districts, and 250 sub-districts. Thank you. Not sure what's happening. We have also, as South Africa, we have identified that we have an adolescent and youth health policy, which is a policy that we follow, and within that policy, it responds also to the South African National Strategic Plan. I will not go through all these policy frameworks and norms and plans that we have for our country, except to confirm that indeed we do have these programs that create a framework for us to work within as we promote the evidence-based solutions for youth health. I've gone through that. The South African National, yes, the evidence-based approaches uses published peer-reviewed literature as well as grey literature around issues of adolescents and youth-friendly services, but there's also a lot of literature around drug and substance abuse that points to the vulnerability of adolescents and young people, HIV, TB programs and the various studies that are there, nutrition and physical exercises, mental illness, sexual and reproductive health, as well as violence prevention. These instruments or these studies, there is data that points to the problems as well as to the possible solutions. I will just highlight that the South African National Adolescents and Youth Policy of 2017 has 6 objectives: to use innovative youth-oriented programs and technologies to promote health and well-being. And we are quite excited that the departments of health are moving away from being just curative. They are also focusing deliberately on the issues of prevention. The second objective is still to look at the areas of high burden, which is HIV, AIDS, and TB for young people through comprehensive integrated sexual and reproductive health rights and services. Thirdly, to prevent, test HIV and TB. And fourthly, to prevent violence and substance abuse. Fifthly, promote health, nutrition, and reduce obesity. This is really a disease of lifestyle. Whilst we appreciate that access to healthy food could also be an economic issue. And last but not least, to empower adolescents and young people to engage with policy and programming on youth health. The logical framework focuses on the activities that need to happen, the specific outputs that are required, the outcomes, and finally the impact. And we know that the impact is a quality of life and reduction of vulnerability, and indeed promotion of wellness that must be achieved for young people. In terms of the national health insurance, this is a bill. It's in Parliament, final stages of Parliament, to introduce universal health coverage in our country, and we're excited that the adolescents and youth health is an integral part of it. In terms of health programs, currently we do have adolescents and youth-friendly services. We've got integrated school health programs where there are also preventative services, for instance, the prevention of vaccination against the papilloma virus. We also have included in responsiveness to youth health standards on ideal clinics. Some of the programs are more youth friendly through peer group and participation. For instance, Be Wise, it's a program that is targeting young people between the ages of 10 to 24, both in and out of school. Secondary targets include healthcare providers, parents, teachers, and other partners. But primarily, it's the youth themselves that are driving this program. There is also a program that focuses on young women. She Conquers, that also harnesses the partnerships that are there and promote responsiveness to youth health for young women. Next, in terms of the challenges, and we can go to the next one. In terms of the main challenges for health, it's a persistent rates of HIV, and this is different for different, the incidence and prevalence are different for different provinces. So we need to also be evidence-based so that we can, appropriately also target and also ensure that the capacity is built more around areas that have a high prevalence and incidences of HIV. TB is still a problem, and both HIV and TB, the prevalence is highest in, for instance, the province of KZN, whereas if you look at the neoplasms, the prevalence is higher in provinces like Gauteng. So there's a need to use data and evidence continuously as part of improving the services we provide and reaching the young people where they are and where they have most need. Unintended and unsupported pregnancy, infections, and substance abuse, as well as mental illness, are some of the key priority challenges that we face in our country. And as I've indicated, we need to be more flexible and responsive to the disparate characteristics one program model cannot satisfy all needs. You need to consider age, marital status, social class, educational attainment, urban, rural, regional, and cultural. Just to conclude, opportunities that prevail for us is to ensure that we move beyond policies and become proactive, especially on preventative and health promoting.
Dr. Gwen Ramokopa, can you hear us? We seem to have lost you this side of the world. Please confirm if you're still available. Dr. Ramokopa? Colleagues, it would seem like we might have lost Dr. Gwen Ramokopa. I did indicate that she was connecting to us from China. Because of connectivity challenges, I suspect we could have lost her. And maybe we'll give her yet another chance. Dr. Gwen Ramokopa, can you hear us? She was almost done though, trying to map up the way forward, given the adolescent health challenges in South Africa. And it does seem like we've lost her. Maybe we could then continue. We'll try and reconnect with her because she's also going to be part of the panel discussion that will follow as soon as we're done with session 2. We're still trying to reconnect with her. Our sincere apologies to that effect. All right, thank you so much, colleagues. Dr. Gwen Ramokopa will definitely reconnect with us, on the panel discussion. Next on the program, we'll be then having a presentation by Dr. Jayati Kusari Basu. She holds a diploma in obstetrics from South Africa. She also has an MSc Med from Wits. She's also a fellow of the College of Obstetrician and Gynecologists from Wits and a PhD from Wits. She's currently the director of the Eguleni Research Center, a JBI affiliate. She's a principal specialist obstetrician and gynecologist, working as the head of the unit of obstetrics and gynae at the Eguleni District Clinical Specialist Team and a joint staff at the University of Witwatersrand. She's affiliated with South African Medical Research Council Center for Maternal, Fetal, Newborn, and Child Care Health Strategies, University of Pretoria. She has presented in various national and international conferences and published many papers in international and national journals. She's an editorial board member of journals and is also a reviewer of various journals. Over to you, Dr. Jayati Kusari Basu.
Many thanks, Dr. Montoidi, and welcome everyone. Very good morning from very cold Johannesburg. My talk will be on adolescent reproductive health in South Africa, and some of these was covered by Dr. Ramokopa already, so I may not repeat. And we will be asking ourselves that is it the time for changing our practice towards the adolescent reproductive health? Next slide. So what is the reproductive health and reproductive rights in South Africa? Reproductive health means it's an access to correct the information regarding reproductive system and sexual reproductive health services. It's an access to safe, affordable, and acceptable method of contraception, which should be affordable by all women in the country, and all women should have access to antenatal care service, including safe abortion services, and all should have access to multi-sectoral services to prevent and respond to gender-based violence effectively. and all women should be able to manage menstruation hygienically, privately, and in a dignified way. What are the reproductive rights in South Africa? It's a right to decide freely and responsibly the number and spacing of their children, and the right to the highest standard of reproductive health services. It's a right to make decisions concerning reproduction, which should be free from discrimination, coercion, and violence. It's a right to privacy, confidentiality, respect, and informed consent. It's also a right to mutually be respectful and equitable gender relationship. In South Africa, sexual and reproductive health rights are enshrined in Section 27 of the Constitution, which provides that everyone has the right to have access to healthcare services, which includes reproductive health care. Next slide, please. So where are we now and where are we going? Adolescents are 10 to 19 years old individuals, and we can divide it into early adolescents who are 10 to 14 years old. Late adolescents are 15 to 19 years old. About 1.2 billion of the world population are adolescents. Highest number of adolescents are actually in Africa, where 60% of the population is under 25 years old. What is happening in South Africa? In South Africa, about 17% of the South Africa's population, which is equal to 11 million, are adolescents. Adolescent delivery rate in South Africa is high at 13%. During the year 2021 to 2022, about 90,000 adolescent girls delivered in South Africa, which is a huge number. And in our own Ekurhuleni Health District, adolescent delivery rate was about 10% in 2022. Interestingly, the population of adolescents and young adults is expected to continue to increase over the next 35 years. So this will make our main focus of today's topic and further work on the adolescents. Next slide, please. So what are the challenges in adolescent reproductive health in South Africa and in fact even globally? So there are broadly two challenges, two types of challenges, that is socioeconomic challenges and health system challenges. So there are various socioeconomic challenges such as sexual and reproductive health education, which is very important, is not a priority to many of us. We as parents are not taught on SRH education to teach our own children at a home environment. And adolescents suffer from increased mortality due to pregnancy-related complication, unsafe abortion, and HIV. And adolescent faces unsafe relationship leading to unplanned pregnancy, unsafe abortion, and HIV. And they are also sufferer of poverty, early marriage, early sexual debut, gender-based violence, exploitational sex, transitional sex. And we must remember that the pregnant adolescent, teenage pregnancy actually have a very big consequences in the socioeconomic factor. Because if an adolescent drop out from the school due to pregnancy, then that adolescent actually is not going to contribute to the economic condition of the country, because that adolescent, if an educated adolescent actually can contribute to the growth of the country, because adolescents are our future. So socioeconomically, even society suffers and the country suffers a big time from the adolescent sexual and reproductive health challenges. What are the health system challenges? We have a wrong perception that adolescents are healthy, and sometimes we might be focusing more on the young adults rather than adolescents, which we might need to be actually changing our focus. Adolescent faces poor access to the health services, again for the same reason that we are judgmental. And when I say we means healthcare worker inclusive, society, community, and sometimes even parents at home, the siblings at home, they might be also judgmental to an adolescent sister or adolescent cousin that who is actually now pregnant. There are limited interventions focusing on adolescent sexual reproductive health services, and obviously there are inadequate financing to adolescent SRH services, or maybe there is financing but which is not being channeled particularly to strengthen the adolescent sexual and reproductive health services. Although South Africa has excellent policies on adolescent sexual and reproductive health services, and many of them are already mentioned by Dr. Ramakopa, my previous speaker, but they have not been implemented in full capacity, and that led to the high teenage delivery rate which we are obviously facing in South Africa. Next slide, please. So I will not actually talk of all of them because Dr. Ramakopa did an excellent job on all this initiative. But just to name that she did mention already, National Adolescent and Youth Health Policy, National Choice of Termination of Pregnancy Act, which is very inclusive and very liberal to the adolescents, National HIV/AIDS Guideline, Integrated School Health Program, then facility level adolescent and youth friendly services. Dr. Ramakopa mentioned already She Conquers campaign. There is Be Wise health app, and there is one subject called life orientation at our high school level, which actually is the sexual and reproductive health educational subject. So which is also, that is actually very highly implemented in all schools in South Africa. Next slide, please. So can we prevent the teenage pregnancy? A big question and very important question for us. So what are the burdens and challenges in teenage pregnancy? About 21 million teenage pregnancy occur globally annually. Highest rate again is in Sub-Saharan Africa, which is equal to 143 per thousand girls aged 15 to 19 years, meaning late adolescent group. Adolescents are at higher risk of eclampsia, CPD, puerperal sepsis, endometritis, and systemic infections. They are also at a higher risk of low birth weight, preterm birth, and severe neonatal conditions. So what are the strategies? Many of these strategies which will be mentioned here, they are already in place. Maybe the implementation part of it, we need to actually focus that how to implement them in full capacity. So just to mention on the all health facilities should be actually implementing adolescent and youth friendly services. It should be mandatory. It will improve our SRH services and it can also improve the SRH education, and that should be at all healthcare facilities, which is not currently happening presently. I mean, at all health facility, maybe some of them are implementing it. All schools should be capacitated to provide comprehensive SRH education to the school children, particularly to the adolescent group, which is also not implemented in the full capacity, or there might be lacks in the counseling quality, probably. That is also something to think about. Health system financing is a very important measure that we need to focus on adolescent SRH services and how we should be implementing that health system financing, that the counseling of the healthcare worker and counseling of the social worker, counseling of the community healthcare worker and ward-based the trainers, that we should be actually spending money on their counseling, because we as healthcare workers, social worker and the community healthcare worker all need to be actually strengthened to provide the counseling to our adolescent group of patients. Because if we are not educated how to treat the adolescent in a positive way, positive attitude, then I think we will be the biggest loser here, because we have a responsibility to improve our services to our adolescents. And of course, I mean, COVID-19 has taught us how the telemedicine, how social media platform actually can save the world. So we can always use effectively and very aggressively the telemedicine platform, the social media platform, to disseminate all the educations to the adolescent sexual and reproductive health challenges, and also allow the adolescents to make questions to us, and we can assist them 24 hours a day by our social media and telemedicine platform. That we might be probably need to think about. And lastly, the big question is that can adolescents be treated as a priority patients in our SRH clinic, which is not happening at present, meaning that if I have 10 patients waiting in my family planning clinic and there are 2 adolescents, can I actually be allowed to actually see those 2 adolescents before other 8 young adult women? I think that's also, we can think about it. That can be a mandatory practice in our health facility, so that they are not turned away and they are not getting fed up of waiting in the queue and eventually discouraged to attend the family planning clinic. And even the community should be engaged in an effective manner, because adolescent also faces the negative attitude from the community when they are pregnant, when they have HIV, and so on. So we can actually create an adolescent champion educator at the community level, which should be run by, there should be a group of adolescent, and taking the community actually at the level of education, so that they can change the community's attitude to the adolescents. Next slide, please. Now we can focus on the unplanned pregnancy and unsafe abortion, which can go hand in hand together. So what are our burdens and challenges? 80% teenage pregnancies are unplanned in South Africa, and 33 to 80% are unplanned globally, depending on which country they are residing. 3 million of them faces unsafe abortion globally. About 60% of adolescents use contraception in South Africa, injectable being the commonest type. Unfortunately, the data on unsafe abortion among adolescents are very scanty. We might need to be focusing on that. Although South Africa has one of the most liberal TOP law, but it's not been implemented adequately at our facility level. We are still lacking provision of the second trimester TOP at the facility level, and we are still quite slow actually to implement this law in full potential. So adolescent will be probably the most commonest people that who will be discouraged of this inadequate facility provision. Adolescent also faces barriers to contraception access, and that's due to mainly the negative perceptions and about the contraception services, and which lead to the poor attendance of the adolescents to the SRS services, particularly family planning, and judgmental attitude of the healthcare worker also plays a contributing role or to that poor attendance. So what could be additional proposed strategy? Some other strategy which we have mentioned before also can actually be added to these challenges. So in addition, then emergency contraception should be very strongly promoted among the adolescents, which can actually prevent the pregnancy. And all health facilities should be actually having a positive attitude to promote it among the adolescent and to provide it to them when they need it. And then adolescent SRH app, telemedicine, media, digital platform already been mentioned. And last but not the least, that parents should be actually included. Parents and the community and should be both included in the educational platform, because parents can do a marvelous job at their home environment, because parents are the main educator of our adolescents. So they should be included in all this program. Next slide, please. So is HIV STI actually preventable among adolescents? A very big question, particularly in African context. So what are the burdens and challenges? About 1.75 million adolescents living with HIV worldwide. Among them, 88% actually living in sub-Saharan Africa, which is equal to 1.5 million. About 6% of adolescents globally, like late adolescents of 15 to 19 years of age, are HIV positive. There are various contributing factors socioeconomically, such as poverty, transactional sex, unsafe relationship, gender-based violence, and of course lack of knowledge, which are all mentioned previously, contribute to the HIV and STI acquirement. So proposed strategies, all previous strategies which are mentioned, plus we should encourage HIV testing of the adolescents at all service delivery point. Wherever they come, they're coming for pneumonia, diarrhea, fever, we should actually allow them to have HIV testing, and the testing should be done by the point of care or rapid testing, so that we get the result and start treatment immediately. And pre-exposure prophylaxis should be strongly promoted among the adolescent. We should not be shy to disseminate this pre-exposure prophylaxis among the adolescent, particularly among the pregnant adolescent, which can actually prevent the HIV acquirement. Dual contraception, there is nothing much to say, that it also helps to prevent the HIV. It should be also promoted very strongly among adolescents, and always we must include partners and parents in all this dissemination of the education. And last but not the least, that boys should be also circumcised, because we know that it's an important tool to prevent the HIV. WHO actually founded a global initiative in 2020 because they are very it's a very hot topic actually at the WHO level. They initiated a initiative named All In End Adolescent AIDS for the whole world. So we should be actually focusing on this initiative. Next slide, please. So we have come to the conclusion side. We have a big challenge as we saw in the previous slide. But good thing is that all the challenges and solutions are actually interrelated, meaning that if we can't actually start reacting or start sorting out one challenge, that will actually have an impact on other challenges of reproductive health. So most important strategy should be to strengthen and put special focus on contraception among adolescents, which in turn can prevent pregnancy, can prevent unsafe abortion, and also can prevent HIV. Next slide, please. So for the recommendation, actually some of the proposed strategy also can play a role for the recommendation, but some additional recommendation, I thought that we should probably work on this in our in next after the symposium. That is, our data collection should be very regular, and monitoring of the data should be focusing on the contraceptive used by the adolescents, and even splitting the data collection to early adolescent and the late adolescent. And then we should create a new health system indicators on adolescent sexual reproductive health, particularly on contraception and unsafe abortion, where data is very scanty. And research should be promoted on adolescent SRH, which are very scanty. There are some ethical restrictions doing the adolescent research, adolescent age group research, and which probably we should look at it, that if we can make the restrictions slightly limited, so that many people can do the research on the adolescent SRH. As we know, research is an evidence, and research actually help us how to implement the measures and action. And I think that every district in South Africa should develop a committee only focusing on adolescent SRH. This committee should be responsible, focusing on all sexual and reproductive health challenges on adolescent, data collection, monitoring, and I think that this committee can do wonder to improve our adolescent and sexual health challenges in South Africa. Next slide. Not next slide, yeah, is the same slide. The thing is that last but not the least is that education is the highest priority to actually tackle these challenges. And what about the education? All adolescents should be educated. All healthcare workers and social worker and community healthcare worker, everybody should be educated, and partners and parents should be educated. All schools should be educated, and lastly, the community should be involved and educated. So education plays a very big contributory role to tackle these challenges. It should be actually a teamwork of all sectors to tackle the adolescents' reproductive and sexual health challenges. Next slide, please. Thank you very much.
Okay, thank you, madam. Thank you for very enlightening presentation. Now I am introducing Dr. Krishnamurthy Jayana. So Dr. Krishnamurthy is the Professor of Public Health, Dean of Faculty of Life and Allied Health Sciences, and Dean of Office of Research and Innovation at Ramaiah University of Applied Sciences, India. He holds an MBBS and a MD in Community Medicine degrees. He received training in research methods at WHO Geneva and holds a postdoctoral research fellowship from Canada. He is the site coordinator for a global health training program for 4 countries, India, Canada, Kenya, and Colombia. Previously, he was the part of the global health team of University of Manitoba and India Health Action Trust, and was involved in their projects across India, Africa, and Caribbean. He is the founder of the Center for Integrative Health and Wellbeing, where he mentors a multidisciplinary team of Ayurveda physicians, yoga, and meditation instructors, as well as the educators to support clients in adopting an integrative approach to lifestyle change. He has over 100 publications that includes journals, books, book chapters, reports, and white papers. He participated as a keynote speaker and an expert panelist in over 50 conferences and workshops of national and international repute. He has been a recipient of Karnataka Association of Community Health Young Scientist Award by National Academy of Medical Sciences for outstanding contribution in the field of community health, particularly in the space of mother and child health. So, Dr. Krishnamurthy sir, now this virtual space is yours.
Thank you, Dr. Nirmalya. Thank you to all the organizers for having me on the show. And my co-panelists have covered a good amount of material in terms of the situation of adolescent health across the globe and in South Africa in particular. The next 10-12 minutes that I have, I'll try and touch upon the status of tribal health and adolescent tribal health in particular within the Indian setting. I'm trying to share my screen. Is it visible? Okay. Dr. Nirmalya, I hope I can share the screen and operate myself, right?
Yeah, you can. I think, kindly give him the co-host.
That would be helpful. So I can change my slides myself.
Yes.
Let me try now. Okay, are you able to see my slides?
Yes, sir.
Friends? All right. Thank you. And let me not take much time and get in. Friends, this is what I have as an outline of my presentation. Just to give you a glimpse of tribal population and tribal health situation in India and the kind of health burden that the tribal health populations and adolescent populations in particular face in Indian context, and some strategies and some systems that we can think as we want to move forward on in terms of implementation to improve the health outcomes in these vulnerable populations. This is a slide that shows how every state out there in the country has some percentage of tribal population, but overall 8% of the entire population. You all know India just became one of the most populous countries, overtaking China earlier this year, and 8% of that population is staggering. And within adolescent population, about 2% of the overall adolescent population of India, which equates to 243 million, is a tribal tribal adolescent population. That can give you the scale of the issue, the complexity of the issue that we can face in a setting such as in India. Just to quickly summarize, I am seeing that not many issues are very different in India as compared to what we just witnessed in South Africa and elsewhere. Yes, communicable diseases continue to be the problem. In addition, there is rise in non-communicable diseases across the world and also in low and middle income countries. We're seeing that even in tribal populations in India as well. Yes, by the very living conditions in places like injuries, accidents, snake bites, difficult living conditions, difficult socioeconomic determinants, and then access to healthcare is so very low. And we have some slides on the kind of status we have in terms of health access and availability for tribal populations and investments, and we face severe constraints in human resource availability for these populations, data system related gaps, and the political disempowerment of tribal people and whatnot. I think the list goes on and on. This is a very nice article I came across, which magnifies the burden and defines as a quadruple burden of tribal populations in general, and even tribal adolescents face the same issues that the tribal populations face, be it communicable, non-communicable, malnutrition, and mental health and addiction. And after there are stats, I don't want to go deep into stats, but probably I want to spend more time on what we can do as at the level of policy, as a group of researchers, and particularly what could be of interest to JBI affiliate, because it's going to do a lot of work on evidence synthesis in this space and influencing policy action as well. Of course, clearly in terms of availability of human resources, be it frontline providers or the care providers, be it doctors or specialists for this population, certainly there is a lot of gaps out there, much need to be done. And this is not just in 1 or 2 states, but pretty much across the length and breadth of the country. Of course, the government of India has responded very positively over the last 15 years with National Health Mission and which gives new impetus to the General Reproductive Child Health Program. And within that, adolescent health program is also of high interest. We have something called Rashtriya Kishore Swasthya. It's all about adolescent health program. A lot of impetus to addressing the issues through programs such as iron and folic acid supplementation, strengthening peer education, and special focus on menstrual hygiene, and having clinics that are more adolescent friendly. And we see that these things are happening. But there too, we see when it comes to tribal adolescent populations, there are gaps in them reaching out to these programs, or these programs are reaching out to these populations. More recently, I think there is a greater impetus to achieve the universal health coverage within the country, and there are large-scale programs being planned. One of them is Ayushman Bharat Health and Wellness programs. A lot of focus on schools and adolescent health there too, and there's dedicated health and wellness, Ayush health and wellness programs as well. These two can offer a wonderful platform to address the adolescent health issues in general, but particularly in tribal adolescent health, there's a lot more that needs to be done through these programs. Just to let you know that there are these opportunities and programmatic platforms that we can leverage to address the gaps that exist within the tribal adolescent populations. One thing that is often neglected, but I think we should bring back the focus, is how do we bring back traditional care into the mainstream. I think in the recent past, there is more interest and more awakening of the fact that we can't deal with them in isolation. There are also efforts to bring Ayush systems of medicine or traditional systems of medicine into the primary healthcare within Indian setting, but there is a lot more that needs to be done, because when we walk into these primary healthcare centers, we see that this traditional and mainstream is again happening in isolation, or probably one being subordinate to the other, not really addressing the community needs in particular. But when it comes to tribal populations, they have their own ancient, age-old practices that often in the process of development, they are getting ignored, getting neglected. But there is a lot of research that needs to be done in terms of documenting it systematically, probably scientifically studying them before ruling them out, and also reinforcing and supporting them, because often we see in some initial anecdotal evidence and qualitative work, what it shows is these tribal healing systems are a part and parcel of the tribal population and culture. We can't really separate it and say that we want to improve the health of the tribal populations or tribal adolescents. How do we give that importance to this? That also becomes very important. Yes, in general, our co-panelists have spoken about it. How do we take the help of adolescents as health ambassadors? This gets reinforced when it comes to tribal adolescents, tribal health populations, and tribal adolescents. Of course, it's not going to be easy when we see that socioeconomic determinants are so very starkly different from the rest of the general population. Additional effort, a lot more qualitative work, inquiry-based formative research work is required to gain the confidence and involvement of these vulnerable groups, and then have them as ambassadors, without which probably reaching out and coverage of those populations will always be a distant reality. In that regard, I think myself, Denny, Nirmalya, we're all more focusing on research and doctoral programs, and we're certainly discussing at this stage how Rama University, where I work, which is in South India, can collaborate with JBI Affiliate Center of Month, which is in northern eastern part. How can we work? And that's where this slide becomes important for us. There's certainly to understand the issues first and then be able to solve them. A multidisciplinary approach is required. It just cannot be a healthcare providers who can take a lead. There has to be a social scientists, economists, and developmental experts, and also tribal populations. I would like to congratulate JBI a month there for a lot of effort to involve and improve the cause of tribal populations. I think that should certainly take us a way forward. Of course, research approaches have to change from being very participatory and community-based. In India, the epidemiological research in the context of tribal health still assumes a lot of importance because at this stage, there are data gaps in terms of the issues of tribal populations and tribal adolescents in general. Certainly surveys are required, and while we come across small articles, they aren't adequately powered, sampled enough. There is a need to invest more into this research to understand the burden in more comprehensively. I am a strong advocate of implementation research myself. I think more so in this group, there is a need, because in India, we can't wait for research to be done and then take it into policy and implement things. We will have to work on the run, on the go. So how do we take the help of implementation research methodologies that already are there to be able to learn as we implement and be able to in real time influence policy and programs? That becomes very important. And needless to say, these programs need strong evaluation methodologies as well. But implementation research is something that I would like to pinpoint and highlight as very critical. And we've used these modalities in larger MNCH programs, in HIV, and we've seen some success. It's high time we take this methodology into tribal health and tribal adolescent health in particular. So my conclusion slide in terms of key summary lessons and some recommendations is, I think we certainly see that tribal health situation is a global phenomena. Within India, it's a national phenomena, and every state has its pockets, and there's a need to really look at globally and locally, and true to the spirit of the session gLOCAL. And yes, at this stage, a comprehensive picture of tribal health is still lacking. While we have some studies here and there, but we see a lot of gaps in these study sample, and there's a certainly need to invest in terms of understanding the situation both quantitatively and qualitatively as well. I would like to bring back the focus on comprehensive primary health care. I think it's getting renewed impetus in the context of urban universal health coverage. Government of India is laying a lot of thrust on comprehensive primary health care, and I feel, especially in the states that have higher tribal health communities, how does comprehensive health primary health care accommodate the needs and addresses the needs of these become very important. So understanding inequities and addressing them as a part of the comprehensive PSC strategy becomes important. Having done that, existing national health programs that do give vertical focus should also not be ignored. And while there are good programs for adolescent health populations, how do we strengthen them? How do we invest more in them to be able to, again, address the inequities between larger adolescent health populations and tribal adolescents that continues to remain, I think, continues to be the need of the hour. With that, I will come to the end of my slide. These are some references that could be of interest to some of you. I'll be happy to take any questions either now or at the end of the panel session. Thank you so much.
Yeah. Thank you, Professor Krishnamurthy, for your enlightening presentation. And now the time has come to have a discussion. So now I would like to, Jayati Madam, please go on.
Is my hand up? No, I did not put up a hand. Okay. I only applauded the presentation.
Okay, great. Yeah.
Thank you
so
much.
There were three presentations. So we have seen. So first one is basically by Dr. Ramagopa. So Dr. Ramagopa is basically she told about the global standards for adolescent health and the South African policies and guidelines. And I must say that or I must applaud that the policies and guidelines are very good. And she also highlighted that there are some challenges, as well as the implementation is not in line with the the policy is written. So there are some challenges, there are some opportunities, but we have lost her in terms of because of the I think some technical glitch. So way forward, she couldn't present. While Jayati Madam has clearly stated that the challenges of adolescent reproductive health in South Africa, the wide prevalent, pregnancy during the adolescent period is a huge problem over there. Then the SRI services, she also clearly mentioned, and how we can prevent the teenage pregnancy in South Africa. Then I know she also gave details of how HIV and STI could be prevented among the adolescents, and how the global standard we can meet. And she also recommended regular data collection, create a new health system that can be sensitive towards adolescent SRH, and promote research on adolescent on a regular basis. So that is her recommendation. And lastly, Professor Krishnamurthy clearly, I think, very articulately stated that how the tribal population or tribal India have been facing or has been facing a quadruple burden of diseases, so communicable diseases, non-communicable diseases, malnutrition, mental health and addictions, and the health services are not adequate or need-based in the tribal population. And the government of India has been trying its best to come up with various adolescent health programs, including Ayushman Bharat school health and wellness program, universal health coverage, obviously. And he also highlighted that why the traditional tribal medicine should be incorporated or integrated in the primary health care, so that can give a kind of a more access to them, more access to the primary health care by the tribal people. So that is what is very important. I think an idea or new thing that can be propagated in our country. And he also highlighted that why multidisciplinary research, then why the tribal people should also be the front runner in terms of participatory or community-based research programs, and then epidemiological research one. And he highlighted or pinpointed the importance of implementation research. Why implementation research is very important, because this can help us to programmatic decision making better, as well as policy framing. So that would be very helpful in the long run. So these are the brief kind of what we have learned from these three presentations. So now the floor is for all. So anybody and everybody can ask anything, any questions, any remarks, or any experience. So that can be shared over here. Yeah. Mr. Paul?
No, thank you, Program Director Paul Butzani from an organization called Shout It Now that focuses on young people, particularly adolescent girls and young women. Just as an observation from Statistic SA here in South Africa, and also stats that is prevalent in the media domain, we see that 1 in 3 women in South Africa are experiencing gender-based violence, and this has it's a scourge. And I just wanted to find out from the presenters, particularly in India, what I have appreciated the fact that there are traditional approaches and also conventional ones, but one is more focused on what technological interventions that they can share with us, so that we may adopt in trying to expand access to gender-based violence prevention and case identification. Thank you.
Thank you, Paul. I think you asked a very valid question, and especially when it comes to adolescent group. Even in tribal groups, we see there is a fair amount of usage of mobile phones and cellular technology, the reach of some of the media is quite out there. And how do we leverage that to be able to communicate the right messages and facilitate right behaviors becomes very important. I should admit, even in Indian context, while the technology has been greatly exploited, but when it comes to these particular populations, and there are also certain geographic locations where we do see gaps, and there's a certainly need to do more of that. I think very well, a point well made. There is certainly a need to step up on that front.
Yeah, thank you, sir. And I just want to add one thing that, that we have already prepared a, mobile application in tribal language, and that mobile application can help the adolescent girls to send the SOS or any kind of, report, to report the abuse if they face anything untoward things to directly to the police. So we have already started this initiative, and that can be, I think, utilized in South Africa also. So and it's a kind of a mobile application, and that can be utilized by anybody. It is being supported by UNICEF.
I think that's a great point. Just to extend that point, what will be required is the tribal culture, context, social concept is so very different. While we use the technology, how do you translate the language, the content into their?
Can I please request others to mute? Please.
Professor Ambika, kindly mute yourself. Yes, sir. Go on.
I think that's going to be the need. The cultural, contextual translation becomes important, and India is so diverse. Within a state or a province, you see much diversity. And while we see tribal populations themselves, we can't see them as one whole. They're so different from different parts of the country. So that is where the need lies. And as Month has been doing so beautifully within that context, likewise, there is a need for more and more NGOs to come forward to take up this translation to meet the contextual and cultural requirements. Well made, Nirmal.
Yeah, thank you, sir. Anything else? Anyone? So if there is no question, then I think we can go for tea. Yeah, please, ma'am.
Yeah. Yes,
No, I was just responding in extension from Dr. Jiana that I think all the adolescent related problem, one point stands out very clearly, that is the education part. When a woman is educated, or when an adolescent studying and not dropping out from the school and going to be an educated woman, an educated adolescent or educated woman can actually raise their voice against any wrongdoing to them. That is one thing. And obviously, I think the adolescent app can create a big wonders, because we have seen it in COVID-19. Actually, having the platform, social media and app, which I mentioned in my I think that should be, very, it is a doable thing. And I think we should implement it aggressively in South Africa, so that every single adolescent, even if they are not in the school, they have a phone, they have a smartphone, and they are very good in using the smartphone. Adolescents are actually better. They are our teacher how to use the smartphone. That's what I see. So I think that will be that will be a very doable thing, and that can be implemented effectively to improve these messages, education, and how to report to the police, how to raise their voice, and how to report to the institutional authority who deals with the gender-based violence and so on, such as shout out. They can immediately report if something happens. Thank you.
Yeah, thank you, ma'am. So anyone? Yeah. So I think one number is there. I think Dr. Basu.
Yes. Oh, I think there isn't. Good morning. Okay. And yeah, thank you so much. I'm Dr. Ntomfikile Mjali. I'm from the organization called Shout It Now. but I consider myself as a public health activist as a whole, and I got to see some familiar faces also in the room, and also lovely to see new colleagues as well. I came in, and I apologize, I came in a little late, and Dr. Ramokgopa was already way into her presentation, but I managed to get the last bits of her presentation and the rest of the presentations as well. I think what I'm hearing all these policies, and Dr. Kaya, let me just read, Kusari mentioned, some of the barriers that we have in the healthcare facilities, especially when we are doing the programming in terms of the adolescent and youth focused. And we know that particularly our healthcare systems and our facilities are not geared to be able to provide adequate support to the adolescent and young people as a whole. I know we can also talk about the fact that they're also not friendly for men, and it's largely seen as spaces for women predominantly. And so we have to be mindful of that. And I like how we are coming up with these solutions. And I think we need to also start prioritizing what is it that is going to give us, and what are the levers that we need to pull to get the most out of these particular interventions that we've agreed on. As shouted now, so how our operating model is that we have mobile, and we work in Ekurhuleni as well. We've got mobile vans that are bold, loud, and you can't miss them, when we operate in the communities. But we also have some virtual platforms that allow young people, particularly young girls, 20 to 24-year-olds who have smartphones, to be able to take advantage of the platforms that we use to share information. I think it's something similar to the BWise app. It's an information sharing, but also we've got a rewards program that rewards young people so that they take ownership of their own health, because largely how we are viewing the way that we view health provision is also, we think we need to be telling young people how they need to behave. And I really think the idea is really to stop being, to lessen the paternalistic approach and allow young people, young women, to take ownership of their own health and their sexuality, including, how they engage, and also make sure that they've got the different options. So we've got this app which we call Eyakomo Girl, which incorporates the behavioral life skills program as well as the biomedical services, and we're layering as part of the DREAMS approach from the PEPFAR guidance. But the importance of that is that they earn rewards, or it's almost like a vitality. So I don't know if you guys know about Discovery Vitality. They earn points for doing the test, for making sure that after 3 months they come for a test, they've checked, and they earn a number of points if they continue to be on PrEP, and if also they are on the Life Skills program. And what we really try and create, particularly in our mobiles, is those safe, non-judgmental spaces. We know that even when we have to collaborate, Dr. Mtwedi, and I say this to you because you're my colleague, but even when we have to, take them on or refer them on to the facilities, there's a reluctance, because now they know, because they've interacted with the healthcare system, they know that the spaces are not the same in terms of, for example, because we do also GBV support, so we screen, and then we have to send them to the Zela centers, and for either access for PEP, and there's a reluctance. We've got a process of following them up and making sure they get access to that. However, we know that that's one of the things that we need to deal with. And my question is really, how do we make sure that we collaborate and really try and not necessarily have, and I agree we should have the adolescent and adolescent youth and youth-friendly services in all the facilities, but how do we leverage resources that are available that might not be DOH-led programs or DOH-led platforms, so that we can be able to reach these populations, and really think about how to but basically connecting all of these services. And that will be my submission. But I really also think we need to prioritize in terms of what is going to be the levers that take us to where we need to go, because the problems are multitude. There's a lot. And then also around the communication, the last bit is around how we communicate the information. Dr. Mtwedi, we communicate the information to young people, but it seems like they're not hearing how we're communicating. And I think we really do need to create platforms where we hear their voices a little bit more in terms of how they want to consume the information. What we've seen in our programming is that young people, particularly with regards to HIV, there is a low risk perception, or there's a low perception of the risk for themselves around getting HIV. Some of us who've lived through HIV and seen people dying of AIDS, we've got more awareness, but the younger generations, I don't think they've got it because they've not experienced people who've died of HIV or from opportunistic diseases that are related to HIV. So I really think that we need to be thinking about how we're communicating and reaching the young people, and then creating platforms where they can.
Okay, got it. Please. So any comments? Further comments? Yes,
maybe
madam?
Dr.
Yeah.
Mukeji, as co-chairperson, maybe before the panelists comment, maybe one could even add these few comments here, especially, all the comments and all the presentations done here, all the implementation that needs to happen, there's got to be something called the political will, and I'm putting this question over to Dr. Gwendra Mokhupa in terms of the adolescents that we're talking about here. They are at schools, they need health services, and they also need psychosocial support. And in South Africa, it talks to 3 different government departments here. We're talking of the Department of Social Development, Department of Education, and Department of Health. How best can we fast track the close collaboration of these 3 different government departments? I think both of Dr. Ramokhupa and Dr. Basu also spoke about the importance of adolescent health literacy and the community support. But we know in South Africa, some of the communities are broken because of multiple reasons, one of them being poverty. So how best, could we be in a position to assist one another to ensure that all that we're talking to here does get implemented? Thank you. Over to you.
So thank you very much. I think if we don't have any more comments, so now we are having, I think, we are a bit late, 15 minutes. So let us cut short the tea break for 15 minutes. So we'll be rejoining at 3:30 for the next session. So thank you all. Thank you all the presenters. And we are thankful for all the comments that we have received. And I am thankful to my co-chair, Dr. Professor Mtwedi. So thank you all. So now we are again going to meet at 3:30. Yeah, ma'am, please go on.
No, I'm just saying that 3:30 is for India, so South Africa will be after 15 minutes. So that should be, I think, what 5 to 12, if I'm not mistaken. I think 5 to 12, yeah. Otherwise, all South African people also will come at 3:30.
No, sorry.
And so much to the previous speakers and the panel discussion that we had. We are going now on session 3, and I'm going to introduce Professor Ute first, and who will be co-chairing with Professor Ekta. Professor Ute holds an FCP's SA MEd Pretoria Diploma in HIV Management, Certificate in Advanced Health Management, and a PhD. She is the co-director of the Ekurhuleni Clinical Research Center at a JBI affiliate. She is principal specialist pediatrician working as the head of the unit of the pediatric and disease specialist team and University of Pretoria. She's director of the Center for Maternal, Fetal, Newborn, and Child Healthcare Strategies, University of Pretoria. She is also the Deputy Director, Maternal and Infant and Healthcare Strategies Research Unit, South Africa, SMRC. She's published many papers in national and international journals. She's been involved in developing many national guidelines and projects. She's a reviewer and editor of journals as well. And the second co-chair would be Professor Ekta, who will be chairing together with Prof. Ute. She's an associate professor and dean at the International Institute of Health Management Research in New Delhi, India. She holds a master's social work and a doctor in public health. She has 25 years of experience in implementing public health programs in India. As a seasoned epidemiologist and social scientist, she is passionate about applying quantitative research methods to address health disparities. Over to you, Prof. Ute and Prof. Ekta.
There you go. Hello, everybody. Sorry, we're playing musical chairs a little bit because our main computer here was kicked out of the system, so we're just getting that back on. But thank you, everybody, for joining today, and we've already had fantastic discussions. And yeah, so we are now on our next session, which is going to have 4 speakers, and so I'm going to introduce the first 2 speakers, and then my co-chair is going to introduce the next 2, and then we will end off with the panel discussion, and then we'll have the closing remarks. So yeah, so our first speaker, so I'm very lucky. I don't, because I'm introducing our first speaker is, or has already been introduced. So it's Prof. Denny, Denny Johns, who everybody already met, who's a research methodologist at the Center for Public Health Research in Kolkata, India. And we are just sorting out, sorry, on our own side, we're just sorting out that we can actually see the slides here. Who's going to show the slides now for Prof. Denny? Sorry, we're just having a little bit of a technical glitch here. Yeah, are you going to share? I can share at my end if it's fine. Okay, yeah, that would help. Thank you. Okay, so thank you for preparing the topic for us, and over to you. We're looking forward to your presentation. Thank you.
I hope I'm audible.
Yes, you are.
Yeah. So I will try to bring some methodology aspects of how can evidence-based healthcare and what could be its possible application in adolescent health. I'm referring to some of my existing studies, but also trying to propose certain new areas so that people can also have a background on what kind of evidence is generated possible across adolescent health. So if you take systematic reviews in general, you have across, so this is from one of the recent co-authored books that I've written as part of for Indian Council of Medical Research. It's a freely available book, and probably I'll share it with the JBI team in South Africa so that it can be shared. It's a freely available PDF. And during that time, we also, one of the things that we wanted to do was trying to understand what are the reviews, what type of reviews are possible across a particular, disease or a population area. And typically these are called as typologies. And we identified in our, we actually looked at previous such similar papers, but also we added some of our own based on some of the work that we've been doing. And we identified around 13 types of reviews where such applications will be possible. So what I've tried to do is, in each of these slides, I've put into 3 kind of columns. The first column tells us what type of review type is it all about. Second is what is the aim of that particular review type. And the third is actually a living example, which is already published from based on adolescent health. What I've tried to do is, how does each of those review type fit into adolescent health? That's the objective of these 3 slides. And then I'll move to an example of an evidence and gap map, focusing on adolescent health. So the first review type is effectiveness. Effectiveness type of systematic reviews try to evaluate the effectiveness of a certain treatment or practice in terms of its impact and outcomes. And the example that I've highlighted is a school-based intervention to promote adolescent health, a systematic review in middle income countries of WHO Western Pacific region. The second review type is focusing on implementation, which aims to evaluate the factors that are associated with any success or failure of implementation programs, projects, or interventions. And for this case, I have used the example of implementation strategies to enhance youth-friendly sexual and reproductive health services in sub-Saharan Africa. The third type is the qualitative, which is focusing more on experiences, which tries to investigate the experience or meaningfulness of a particular review. The example that I cited here is focusing on emotional distress among adolescents and what is the qualitative components for the relationship of perceived cause and health seeking behavior. The typology of types of reviews. The fourth one is the barriers and facilitators. But this is becoming very important in today's world of implementation to understand what are the factors that act as barriers or facilitators for increasing access or uptake of the program. In this case, I've taken the example of physical activity among children, also in young adults. Diagnostic test accuracy. This is the Cochrane group has got a diagnostic test accuracy group, from where some of the methods of assessing diagnostic test accuracy to check how well a diagnostic works in terms of its sensitivity and specificity for a particular diagnosis. In this case, I have taken the example of the systematic review on diagnostic test accuracy of serum procalcitonin compared with C-reactive protein for bone and joint infection in children and adults. You have etiology and risk, which is an important factor. In this case, I've taken the example of influence of social media on depression, anxiety, psychological distress in adolescents. Etiology and risk type of reviews look at the association between particular exposures, risk factors, and outcomes. The next one is on prevalence and incidence. This is to check if you want to understand what is the prevalence around a particular disease, area. In this case, common mental disorders prevalence in adolescents, where we can do a systematic review and analysis. Psychometric type of systematic reviews focus on how reliable and valid is a particular test or assessment. Here I've taken the very selected child and adolescent preference-based measures, which are used to predict utilities for child and adolescent, something that is very important when you're doing cost utility analysis. A cost or economic evaluation type of systematic reviews try to determine the cost, but also the cost effectiveness. The example that I've taken is systematic review of economic evaluations or interventions for high risk young. You have prognostic type of systematic review, which looks at the overall prognosis of a condition. It can also link between specific prognostic factors and outcomes, looking at prognostic models and prognostic tests. The Cochrane prognostic methods group, is one of the newest groups in Cochrane. And here I've taken the example of systematic review of childhood and adolescent risk and prognostic factors for recurrent headaches. It also look at methodology, which tries to investigate current research methods and their potential impact on research quality. For example, here I've used the example of measuring mental wellness of adolescents, a systematic review of instruments. Predictors type of systematic review focus on factors associated with a certain condition. And here I've taken the example of the predictors of adolescent sexual behavior and intention, a theory-guided systematic review. And finally, you have the review type, which is focusing on expert opinion or policy, and which looks at review of to synthesize current expert opinion text or policy on a certain phenomena. In this case, I've taken the example of evaluating quality in adolescent mental health services systematically. The objective for sharing this typologies, which if you notice is almost, I think it's around around 13 types, is to clearly show that beyond systematic reviews or can be extended beyond the effectiveness type people usually assume that it's only effectiveness type of systematic review that is possible, where we use the classical PICO framework, the population intervention comparative and outcome. However, when you look at these 13 type of applications of systematic review methodology, you will notice that there are a lot of other variations that come into picture when such reviews are being done. For example, in the etiology or risk, you're more looking at population exposure outcome compared to a PICO, which is more relevant for an effectiveness or an implementation type of systematic review. When you're looking at a prevalence or an incidence, you're looking at a condition context population, COCO-POP as we call it, rather than again the classical PICO kind of logic. And for example, when you're looking at cost or economic evaluation, you're looking at population intervention, comparator outcome, and context. Because in economic evaluation or in cost, context is a very important factor of consideration. Because what is cost effective in South Africa might not be cost effective in India. And that is where the context becomes part of the understanding when evidence on cost effectiveness or economic evaluation is considered. So the objective to share was that across this, while we're developing understanding on evidence on adolescent health, it's also to understand that there are these various types of typology that can be used to understand various nuances of adolescent health across these 13 types. I want to move towards a very general evidence which is available. So I'll just use the link that I want to use because I felt that it is very useful to go directly to that part compared to. So this is. I hope everybody can see my screen in the evidence and gap map.
Yes.
Okay. So this is an evidence and gap map managed by UNICEF, which focuses on adolescent well-being in low and middle income country, and it looks at 4 factors: protection, participation, and financial and material well-being. And evidence gap map is basically a methodology where you try to encompass all the evidence around a topic. In this case, it is around 4 domains of adolescent well-being, which is protection, participation, financial, and material well-being. And it tries to look at what are the intervention areas and what are the outcome domains across these 4, well-being factors. Right. So just to explain how this, so you'll notice that protection, participation, financial and material well-being, and finally they have created an enabling environment. And the entire evidence comes from a systematic review methodology. However, once the difference between a systematic review and an evidence gap map, especially which is useful to understand, is where systematic reviews try to understand between one intervention or the other, or probably very narrow. Evidence gap map is try to bring much broader picture. It is usually used in a diagrammatic or a figurative manner for presentation. And one of the ways that you represent is using some kind of a 2x2 table with some kind of visual representation to understand what kind of studies are out there for this. So for example, let's take one example, and you notice that what we have here is we have 6 type of studies. There are 6 papers that have come from financial support kind of intervention, which is the broad intervention category. And if you look at outcomes as protection related attitude, knowledge, and skills, then it tells me that there are 6 papers which are focused on this. And this is the way in which you can say that, okay, and what they have done is you can actually use the link to go back to the systematic review that has been identified or as part of the evidence available. So what it helps you to understand is what is the evidence available on adolescent health across all these domains, which includes both primary studies, impact evaluation in this case. They've also highlighted systematic reviews. That is what the blue and the green parts represent in this case. So the green, so for example, here when you say 0, that means there is no systematic review published around this topic. And for the groups which are focused on developing systematic review questions, this is a very good approach to where systematic reviews need to be conducted around adolescent well-being. That is the value of such a gap, rather than trying to find out. So you notice that there are 6 reviews or 6 studies, impact evaluations already available. it's very easy to say, yes, there is a good possibility that I can do a systematic review or a meta. It will not end up being an empty review. In this case, where ICT is concerned regarding participation and financial support, you notice that there is a gap which represents the need for primary research around the topic, and that is the attention that gives us by these blank cells. So that is the gap, that is the gap component of the evidence and gap map, because it's kind of a navigation, that's why it's called a map, and where evidence exists and where it doesn't exist is highlighted as a gap. So this is, you'll notice that a lot of components around financial is available, but for example, if you take the example of a group financial support as an intervention, at the community level, there is hardly any evidence available in terms of primary studies. The same is case. However, if you look at financial literacy and some kind of, you'll notice that the studies of numbers are spread across these outcomes. However, the number of studies conducted between them is quite low. Now, again, we have to take into consideration that this is the evidence that is focused only on low and middle income country. It's not a global evidence map. So that is another limitation. However, this actually tells us that the well-being component of evidence and gap is quite limited as far as the LMC is concerned. So this also helps us to understand where should the new research be funded or conducted, including academic institution, masters or PhD thesis, and also how to identify priority areas for systematic reviews so that we can use that evidence for building better, provision and quality of health services as far as adolescent health is concerned, especially in low and middle income country settings. You'll also notice that there are some related evidence and gap map in this case. So, for example, if you want to look at an adolescent sexual and reproductive health, there is another map around that. If you are looking specifically to reproductive, maternal, newborn, child, and adolescent health around social behavioral and community engagement, there is another health map. There are cash transfer map. There is a evidence for peace building and a health map, and also related to education and youth and transferable skills. So the objective of such evidence map for UNICEF and or for institutions like JBI South Africa or for us, for example, is to also build in indigenous health component. You will notice that there is no single outcome at all, and that is why groups like the Kolkata-based organization that I represent, called Center for Public Health Research at JBI Center, is to highlight that what is the evidence of indigenous health and its relationship with adolescent health available. So this is the value that I think is missing in terms of the areas of adolescent health. I would be stopping here and trying to, we'll take a break. We'll just stop here in case there are any questions or any comments to answer. Thank you.
There you go. Sorry. Thank you very much. That was very helpful. We do need to move on, so we'll come back to the discussions later on. So, but thank you for setting the scene so well for this session. Our next speaker is going to talk on Indigenous adolescent health promotion through community media. We have already met Dr. Nimalaya Mukherjee, who's from MUNT and who is a professional social worker by training with a master's in public health and a PhD in mass communication and journalism. I'm really looking forward to this talk. So over to you.
Yeah, kindly give me the co-host status so that I can present it.
Okay, co-host status, please. Okay, I'm told you will be able to share.
Yes, I can.
Yes, thank you.
So is it visible? Hello, is it visible?
Yes, it's visible.
Okay, so my topic is, indigenous adolescent health promotion through community media. So here in India, we have been using the word tribal, than indigenous people. So in most of the cases, we have been using tribal population. So just for understanding, I'm just giving this that I will be using both the terms, both indigenous as well as tribal population. So now, what is community media? So community media is basically a platform to give the kind of avenues to the people so that they can air their voices and choices, and thereby they can acquire the critical knowledge, which is very important. And two words are very important in community media. So one is participation, another one is dialogue, and both are related. So participation of the community people means in community media, obviously, the production of the contents, the broadcast of the same, as well as discussion, deliberation, even the interpretation of what the program or the radio program or community video program is trying to percolate. So all those stuff can be the part and parcel of participation. And participation is basically dealing with three things. One is dialogue, debate, and deliberation. So dialogue is always there. And for this purpose, the dialogue is very important. But and I must say that the famous Brazilian theater personality Augusto Boal has clearly mentioned that there is an oppressive relationship in which there is only monologue and not dialogue. So dialogue is a must. So monologue means only the manifestation of the oppressors. So it's kind of a not related to our development or and I must say that dialogue is emancipatory in the niche in its approach. So why the voice matters? So because we can speak, but we should be heard. So both the things are very important. So community media is basically giving kind of a space for the tribal people, for the tribal girls to speak of their minds, to make their history, to make their culture visible. And while the mainstream media failed to do so, so they are basically, mainstream media is basically looking after the political news much more than, the community people's needs and other things. And so this is a kind of a participatory production process which leads to emancipation, who would be involved in community media. And community media is basically different from that of market as well as government, led media services. So it encompasses community radio, community video, then mobile IVR in tribal languages, the publication of newspapers out of the, or rather I can say independent of external control, then social media also. So these are all those things. And it is very important for a country like India, where 70% people, more than 70% people living in rural areas, and there is no media for indigenous people. So just one example that, that in 2011 census, we have seen that only 45,000 people said that Sanskrit is their mother tongue. Sanskrit is one of the oldest language in the country. And there are so many broadcasters, so many, newspapers, media channels are there. But, in our area where we have been working for long, almost 62 years, so only bearing our, radio station, there is no media. So there is no radio bearing hours. There is no TV channels. There is no newspapers, nothing. And in India, we are having many languages. So more than 10,000 languages. And there are, many languages are basically, endangered, rather I can say. So it is an embarrassment for a country like India to lose any language, because that can hamper the overall development of the indigenous people, and it can also lead to the diverse culture. So what we have been doing, we are basically running a community radio station since 2010, initially with support from UNICEF till 2015. We have been regularly broadcasting in tribal languages from 6 a.m. to 9 p.m. And there is a special focus on technology promotion, science communication, education, agriculture, health, their culture, the history. And there is a system that, that all the programs are being managed by the community members. So they have been identifying the issues and the communication needs, the expectations as well as responses. And thereby we are coming up, we are facilitating the community dialogue so that the content development would be focusing on solutions Then we prepare the draft radio magazines. Then we again going to the tribal villages. We are calling it narrowcasting. So narrowcasting means, we are carrying the audio system, and we played the audio system, audio magazines in front of the tribal people, and they also give kind of a suggestions, or they can also say that this is not the way how we can do it, or how should we do it. So they can also be involved in this, and then thereby we can come up with a final product which would be broadcast through our radio station. So we have been doing this thing in a southern part of West Bengal, that is Purulia district, in 3 blocks, almost having 300,000 population, and the district is basically proverbially poor in terms of 49% multidimensional poverty is there, highest in the state, and second lowest per capita income after Uttar Dinajpur. Based on Human Development Index, it is ranked 16th out of 17 districts of the state. Then in terms of healthcare indicators, tribal people are very, very far lagging behind, which is very alarming. Then there is no, what I have already told you, there is no media in the target area, and the limited knowledge about the healthcare services. So in our case, what we have seen that there is no availability of any information education and communication materials in tribal languages. What we have seen that most of the adolescent, targeted adolescent, campaigns are in Bengali language, not in the tribal languages. Then tribal adolescent, especially the tribal girls, they seldom go outside their villages, so they have a limited exposure to the information. So widespread information poverty is there. The non-health tribal health workers are providing them health information, obviously not in their language. So that is another one problem. And the effectiveness of the effectiveness of the behavior change communication, how that has been impacting the lives of the tribal people. So that is another one area where we are focusing on. And there are the 2 program objectives. One is to promote changes in social norms and behaviors pertaining to menstrual health and hygiene, and in focusing on building the capacity that the tribal tribal girls can utilizing the community radio, podcast, narrowcast, and videos. So that would be the another one thing. Then we have used the experimental design. So repeated cross-sectional studies have been done. 50 tribal villages as experimental group, and 48 tribal villages as a control group. So women or girls aged between 11 to 19 years were selected randomly, and baseline and impact study have been done. So there are 3 intervention model. One is behavior change communication in tribal language, and we focus the stage theory, that is stance theoretical model. So we always believe that every information is not for everybody. So there is some specific need-based information sharing. So that we have done. We are focusing on capacity building of the tribal girls, then participation of the informal in leaders and their traditional village assemblies, because in tribal world these very people are very powerful, and the tribal village assemblies are basically the most abiding by kind of a system. If you are not going to abide by their decision, then you will be outcast. So we have been using that model so that we can reach maximum possible number. Then we have been producing the radio programs, the live phone-in programs, then community videos. We have been focusing on personal anecdotes, and this is very, very important. I will tell it later also. And the screening of community videos, so produced by the tribal girls. So baseline study, basically, the COVID created a huge problem for us. So there is a gap in between various intervention model. So the baseline study conducted during January 2019 to February 2019. The intervention, what I have already told you, that there are some gaps also from 1st April 2019 to 30th November 2022. Then we have conducted the endline study from December 2022 to February 2023. So there are cross-sectional studies. 465 girls were selected, and pre-tested interview schedule have been used. So we have used radio magazines. For 25 girls were trained, and they were trained in storytelling, editing, as well as live phone-in programs, expert interviewing, then how to scripting the radio drama and narrowcasting. So same way the community videos also, the training program on scripting and storyboarding, then videography, editing the finalizing of videos, and screening and feedback. So all those stuff we have taken care of. So this is one example that, personal anecdotes are very important. So this we have seen that personal anecdotes are much more effective than any expert interview. So after this, this very intervention, we came to know that. And the community video process is very, very, unique in that sense that we have been selecting the, girls from the community, and they were trained. Then the editing has been done by the experts. Then, narrowcasting have been done. Then the finalization of the videos, then community screening. So it's a kind of a, the narrowcasting that is going on, audios and videos. So that is what is an important part, because this part is very important to reach out to the targeted community. So training is an integral part of the program. So this is the social media campaigns in Bengali languages. We because it would be understandable. So that's why I have given the Bengali, not the Santhali one, the tribal language. And we have covered almost 250,000 people through various programs, and there is a change in both in knowledge and the utilization. So we have seen that that there is a change in terms of that hygienic practices. So it is from 43.5% to 73.1%, and the use of sanitary pad or sun-dried cloth, we have seen that from 23.9 to 66.7%. So there is a huge change. And what we have seen that the trained girls become the role models, and more girls are coming to the radio station for program development. So initially there was a very much I think skepticism among the tribal people. So they won't because it's a prejudice and kind of a social taboo is related to the menstrual health. So initially there was some resentment. But when a woman, she came to our radio station and shared her experience, and then created a ripple effect. So I must proudly say that next 3 months we have a full of or anecdotes for a program that we are calling it a Nari Katha. That means tale of women. So that is very important to note. Secondly, that that additional attitudinal changes among the husband, other family members, and the community leaders. That this is very important thing. So that and the menstrual health related discussion that have become a part and parcel of the community village assemblies. So another one important change that we have noticed. Then creation of social support, availing the menstrual healthcare services, especially the sanitary pads, even in the community itself, and use their natural talents and creativity in preparation of the programs that we have been focusing, because they are naturally gifted. They can write a song, they can sing a song very promptly. There is no need for any kind of external support needed for them. We have faced a huge challenge because of COVID-19 as well as the lockdown. So and the program became very, very hampered because there was no flow. Lastly, that the conclusion that the bottom to top approach is very cost effective. So here we have minimal investment at the top, and the most of the investment has been done at the training as well as the campaigning or radio programs. Then the different culture, languages, dialect, custom given the priority, so that everybody and anybody would be on board, even to reach out the last mile of the population. Then narrowcasting and community screening are very, very important, as well as the personal anecdotes, what I have already told you. And the culture of cooperation and community ownership are the most essential part to reach out to the adolescent and can have a change effect. So if what we believe, the Chinua Achebe's famous words, or rather saying that that if you don't like someone's story, write your own. So thank you very much. Hello.
Yes, thank you very much. Sorry, we're trying to get our technical stuff sorted out here. Thank you very much. That was fantastic, and we certainly heard you, so thank you. I am going to hand over to my co-chair to continue the chairing of this session.
Thank you, Professor Rute, and thank you to the speakers who have shared very interesting information and knowledge in the domains of adolescent health and what we can do to make things better. I would now like to invite Mr. Andani Singho to make his presentation. Mr. Singho is a researcher at the University of Pretoria in South Africa. He holds a BA degree in Government Administration and Development and a BA Honours in Development Studies, along with a certificate in Office Management. Mr. Singho is a departmental administrator at the Department of Public Health Medicine in the Steve Biko Academic Hospital, Pretoria. He also manages the JBI Clinical Research Center, and he has been involved in multiple research projects that focus on developmental studies, especially for adolescents. So, Mr. Singho, over to you. Thank you.
Thank you, Prof, and thank you, colleagues, for joining in today. My name is Andani Singho from Public Health Medicine, as introduced by Prof. So my presentation will be based on the adolescent case study in South Africa. I just need to change the slide. Thank you. So this will be my content of my presentation, which I will present today to you guys. The presentation will consist of the Tshwane district, the health service lab, which will be in Atteridgeville, and the current adolescent health indicator in Atteridgeville, and the findings and discussion and conclusion. So we will start with the Tshwane Health District, where we will talk about the content of the South African health system, which is based in legal framework listed here. So this I won't be taking you into details because it was presented from my colleagues from South Africa, which is Dr. Ramukupa and Dr. Kusari. So it was all presented because okay, sorry. On this slide, it shows the South African legal frameworks, which would be the Constitution of South Africa and the National Health Act and the National Health Insurance Bill. So the South African health system is divided into public and private sector and organized in 9 provinces. So, and which also consists of 5 districts and 250 sub-districts. So my second slide is the Tshwane Health District, which is one of the 552 districts which were mentioned from the previous slide, and is one of the capital city in Pretoria. So if you see on my slide, this is the map of Tshwane, which we are going to talk about on my case study. So now we'll move on to our health service laboratory, which I'm going to introduce to my presentation. So the health, sorry, I need to go back, sorry. The health service laboratory, it provides the one-site learning aspect for the researchers and health professionals and managers and policymakers and other stakeholders. So this also helps the real environment and consists of routine available resources. So in short term, it means that we don't use other resources to implement this health service laboratory. So we use the same resources that is already there. So which will be the same clinic in the community or the same private clinics which are already there. So we use the same resources on this health service laboratory. The second part is that it is a unique public sector initiative that seek to test implementation for policy and in a control setting. It also highlights latent clinical, social, and health system related issues that will impact both and positive implementations. It will also utilize internal resources to generate evidence support, policy to formulation and informed decisions related to implementation, and therefore translate research into practice, as mentioned before. So we use the same resources that we found at the community. So on this slide, this image, it tries to capture the concept of a health service laboratory. There are 8 health system blocks, which, if you can see on my slide, they are the ones which are in blue, in color blue, which is the leadership going so forth. They are all the health system blocks. They were introduced by the WHO in 2007. In the middle part, this is, if you see, it looks like a house. In the middle part on my image, this says part of the social determinant of health, which is where now we need to focus on individual and in the community from the side. So this gives you the all and the understanding from the community, which comes from if they're employed, if they're unemployed, and if you need to understand whether what is the problem in the community, which has been identified. So if you see on top, there's inputs, which the input is the health policies. We start with the input, going to the process and output and output. So the input is the policies. Let's say we put an example on the adolescence policy. So this will be the policy that was being drafted. Then that will be our input. The process is when we start to look and process the policy that was being already put into the table. And the output is when now we implement the decision from the policy to see if it's going to work or not. The output is to see what if we've achieved, because in each and every research, you know that it should be effective or ineffective. So we will have to determine from the outcome from our research. So the second slide that I've displayed, this slide is just to show you some of the characteristic traits of a health service laboratory in Atteridgeville, which is one of the township in Tshwane. So the characteristics that we have come up with is the geographic defined area, which we have identified the Tshwane sub-district 3, which will be in Atteridgeville. So these are all just the characteristics that will. Sorry about that. Can you please mute the person who's unmuted? Thank you. So the identified area on my slide is Atteridgeville. So now we are going to focus on the case study that we have put together to present today. So the area, if you can see on your slide, is the area of Atteridgeville with different areas, which it is consists of 9 wards. So at Atteridgeville, these are the shown characteristics of Atteridgeville when it was formed and how it was named, and the languages that are spoken in Atteridgeville, and the area and how big the area is. Going to the other slide, this slide shows the number of health facilities in Atteridgeville. So the number of health facilities in Atteridgeville, sorry, I'm on the wrong slide. This slide is the one that shows the health facilities that are in Atteridgeville. So the Atteridgeville, it consists of 6 healthcare clinics, which are namely Atteridgeville Clinic, Bupulong Clinic, Gazankul, and Lotus Gardens, and Bupulong and Sourceville. So we also have 1 hospital, which is Kalafong Provincial Tertiary Hospital, and also 3 private clinics. So the second slide, the slide that I'm going to present to you is the population area in Atteridgeville. So on this slide, we will only focus on the red bars because we are now focused on the adolescents. So the adolescents on the right bar shows that the adolescent population in Atteridgeville and the 6 clinics, which shows that the highest is in Lotus Gardens with 17%. If you can see, Lotus Garden is written as LOTC. That's Lotus Gardens, which has the highest, and the lowest is in Bupilongo with 7%, which is abbreviated as BOCP. So now I will go to the next slide, which we are going to present the health indicators for adolescents collected routinely in South Africa. On this slide, we listed all the adolescent-related health indicators. For this presentation, we'll only present or focus on two PHC, which will be the head count and the PHC utilization rate for the adolescents. This slide shows that the two indicators and how they are calculated. As it shows on the slide, we calculate the head counts as numbers and also have calculated the PHC utilization rate as denominators and also the numerators for head counters. Going on to the next slide, this slide is the adolescent health indicators in Atteridgeville. So we group two into two graphs. So the first graph, which you can see on top, it talks about the adolescents and the adults, and the other group is for the adolescents. So this graph shows the PHC utilization rate for adults and the adolescent in Gauteng Province, Tshwane District, and Atteridgeville Health Services Laboratory. So the PHC utilization rate for adults is higher than the adolescents, as you can see on the presentation. The PHC rate for adults in Atteridgeville, you can see it with a green color, and it is better than the Tshwane, which is in red color on the presentation, but it's less than the Gauteng one, which is blue in color. Similarly, trends is found for the adolescents, which you can see it on the presentation with the yellow color. Coming to the next slide, we will now present the PHC head counts for the adolescents from age 10 to 19. The PHC head count in number among the 6 clinics in Atteridgeville showing a mixed pattern, with Phumulani has the highest head count. From the presentation, from the graph that I'm showing you, you can see that Phumulani is the one that has the highest head count. Presenting the PHC utilization rate from the adolescents from the age of 10 to 19. This graph shows that the PHC utilization rate in 6 clinics with a mixed pattern. For Lotus Gardens, which, if you can see, Lotus Garden will be in purple in color, is always low due to the low head count and bigger adolescent population. So if you can see, I'm not sure whether on your screen you can see the shapes of the oval shapes, which I have put on my graph, which shows that the seasonal variables are shown by the shaded area are always low when the year started. If you see in January 2022, it started low and it changed, and the utilization for the adolescents start to react and going up. But when it reaches 2023 in January, it also drops again down, which means the utilization it differs from seasonal. Findings. So the findings is that the adolescent population varies between 7% to 17% in 6 different sub-populations catered by 6 clinics. The second finding was that lower utilization of PHC services by the adolescents in comparison to the adolescent population. PHC utilization rate varies within the same area, which is in Atteridgeville. The PHC head count also vary among the 6 clinics in the same areas. So the other finding that is that, which I have already presented from my previous slide, it says that it changes seasonally. Variation exists with lower head counts at the beginning of the year. So the discussion, the geographical variability within the defined population which is Health Service Laboratory, demonstrated the need for study in such a study setting for generating evidence, which will be the defined geographical area, which will be the defined population. Lower PHC utilization rate among adolescents need further investigation. Variabilities in PHC utilization rate and PHC headcount in sub-district 6 population served by the different clinics will require also further investigation. Conclusion: the analysis of routine data, which is such as a DHIS data, could generate evidence for decision making. Health Services Laboratory to be used as a study settings to generate evidence and to implement programs to understand the effects of various determinants. Thank you.
Thank you, Mr. Anandini Singho, for this overview of the Health Service Lab and how it can be leveraged to improve the health indicators for the adolescents. I strongly feel that the lab has immense potential to systematically analyze the data and change it into appropriate interventions so that we can make health services more accessible to the adolescents. I would now like to invite our next speaker, Ms. Sunita Kar. Ms. Sunita Kar is a gender and human rights expert with 22 years of experience. She is National Program Coordinator at the Rescue and Relief Foundation in Kolkata, India. She has been at the forefront protecting the rights of women and children, protecting domestic violence and sexual harassment. She has expertise in communication for development, social mobilization, advocacy, case management, and linking government, judiciary, and civil society for the promotion of human rights. Sunita holds a double master's in social work and history. Ms. Sunita Kar, over to you. Thank you.
Thank you so much. Thank you so much. Good afternoon. As you are aware, I'm from the country of Gandhi, who like all great men believe that good health is a real wealth, not any piece of silver and gold. So today I'm going to start my session. This is the Kolkata demographic profile, and you will get some idea about Kolkata, the city of joy, city capital of West Bengal state, India. Estimated population of 4.6 million, sex ratio 899 is to 1000. Hinduism represents the largest religion at 78%, Islam 20%, Christianity 0.9%, Jain 0.5%. And the adolescence percentage is 28.32 and women 46.65. Medical facilities, medical colleges, medical research institute, private and government hospitals, clinics, free dispensaries run by municipal corporation, charitable trust, state-operated clinics, etc. Today we will focus on two important issues. One is anemia and other is teenage pregnancy. So data from Children Protection Home and Community. I have tried to collect the data from my protection home and community to show the health status among these adolescents in last 8 years. If we watch this data thoroughly, then we can see the rate of anemia and teenage pregnancy are higher in the community than in the protection home. While a girl usually comes to the protection home with several health issues, maybe physical, mental, but we can intervene them methodically by taking support from health physician, psychologist, and caregiver, which is not possible in the community. These charts I have prepared following this data. We just go through it. The same things are here that I told you earlier slides. Now the next, these data have been collected from National Family Health Survey 5 India. First table has been prepared to show the percentage of women aged 15 to 19 who have begun childbearing during 2019 to 21. And this second table shows anemia among women aged 15 to 19 years in 2 years. You can show the difference in 2015, 16 and 2019 and 20. You can watch the 2019 and 20, the rate is really higher than 15, 16. Challenges associated with the anemia that we faced really in our field level. Nutritional deficiencies. Anemia in adolescence is often caused by inadequate intake of iron, folate, and vitamin B12 rich foods. In West Bengal, where malnutrition is prevalent, limited access to nutritious food and the lack of awareness about balanced diets contribute to nutritional deficiencies. Menstrual health. Adolescent girls are at high risk of anemia due to increased iron requirements during menstruation. However, limited access to sanitary hygiene products and inadequate menstrual health education can worsen anemia rates among girls in West Bengal. Poor dietary habits, unhealthy eating patterns, including a lack of diversity in the diet and low consumption of iron-rich foods, can contribute to anemia in adolescents. Limited awareness. Lack of awareness among adolescents, their parents and communities about the importance of a balanced diet, iron-rich food, and the consequences of anemia can hinder prevention and treatment efforts. Limited access to healthcare. Limited access to healthcare facilities, especially in rural areas, can hinder timely diagnosis and treatment of anemia among adolescents. Lack of access to iron supplementation programs and regular health checkups can contribute to the persistence of anemia. Socioeconomic factors. Socioeconomic challenges such as poverty, limited healthcare facilities, and low educational attainment can hinder the availability of nutritious food and access to healthcare services. These factors contribute to higher rates of anemia among adolescents in West Bengal. Now the challenges associated with the early pregnancy, teenage pregnancy. Lack of awareness and education, limited access to healthcare services, early marriage, health risk and complications, social stigma and discrimination. I'm going to the next slide, case study 1. 3 case studies from Kolkata I am going to share with you. The first case study is the case of Ranu. Ranu belongs to a very poor family. Ranu and her sister suffered from anemia and Ranu was the weakest among them. As she helped her mother in household chores, she could not continue her studies. Ranu ran away from her house as her mother physically abused her and forced her to get intimate with the stranger. After that, she gets a shelter at Sukarna Children Protection Home, that is a government home, for 1.5 years, and then she was again restored to her mother by the CWC order. After 1 year, she again escaped from her house, and due to her physical illness, she was found senseless in the street and rescued by the local people. There is a flow chart that I have made. We can analyze the causes. Firstly, poverty, then lack of balance of diet, anemia, school dropout, child labor, physically and sexually abused, lack of care and protection, ran away, rape, trafficking, everything has happened with the Ranu. Intervention that we have made, she was given emergency medical support and placed in a protection home again for her care and protection. Nutritional and medical support were provided to keep her fit and fine. Educational guidance, joyful learning, and personal grooming sessions have been provided. Vocational training was given to her. Counseling, rational emotive therapy, cognitive behavioral therapy, and behavioral modification therapy to improve some her maladaptive behavior. The outcome, after 8 months, Ranu again escaped from her with another girl child, Viva, who was a rape victim. They both sought refuge at Ranu's relative house. Unfortunately, Viva was raped by Ranu's grandfather, and they planned to traffic her to Bangladesh. Our staff and police, as soon as they had received the information, and rescued them, both of the girls. Now we are going for the case study 2. Again, this story is from our Children Protection Home, which is registered under JBI Justice Juvenile Act. This is a case study of Pooja. Pooja was anemic and feeble since her childhood. She was sexually abused by a plumber and got pregnant. Her abortion was not possible as she was 7 months pregnant. The mother had somehow managed the doctors and was able to take Pooja home with her. After 3 months, she gave birth a dead child. Again, we can analyze the flowchart. She was not accepted socially by her biological mother. She is abandoned. Lack of proper immunization, balanced diet, immature physical and mental health, anemia, malnutrition again, lack of awareness of reproductive health, sexually abused by a plumber, teenage pregnancy, school dropout. So we make the intervention like this. Hospital authority informed the police, the child welfare committee for the child security. Her mother had lodged a FIR against the plumber and he was arrested. Nutritional, medical, psychological therapy and counseling support were provided. Educational guidance, joyful learning and personal grooming sessions were provided and vocational training was also given to her. At present, she has been restored to her family and she is continuing her study. And the third case study and last case study, I have selected this from the vulnerable slum community in Kolkata, where the environment is not child friendly at all. Moreover, high population density, absence of basic and essential facilities, degraded environment in sanitary conditions, etc. We can say substandard housing environment. This is a story of Mani. Mani belongs to a very poor family. She is malnourished and anemic since her childhood. One day she went to her school but did not return back, and she had been trafficked. Cause, there is a flow chart that indicates the cause of this incident. Again, poverty, lack of balanced diet, malnutrition, anemia, physical and mental growth, hindrance, education hampered, forced to child labor, child marriage, chances of dropout, trafficking, prostitution. And the intervention was, we have investigated the case and was able to trace her whereabouts in Pune, Maharashtra state, India. Finally, with the support of the social branch of Maharashtra Police and National Commission for Protection of Child Rights in Pune, the girl was rescued at last. Outcome, after the rescue, she was transferred to the Children Protection Home by the order of Child Welfare Committee. The home offers a safe environment and an integrated approach to all aspects of child care, including shelter, education, nutrition, and health for emotional, social, and cultural and cognitive development. Now the interventional strategies, next slide. Addressing the challenges of adolescence, anemia, and early pregnancy in West Bengal requires a multifaceted approach involving various stakeholders. Here are some strategies and interventions that can help minimize these issues. Comprehensive health education, implementing comprehensive sex education programs in schools and communities. This education should also cover the importance of nutrition and way to prevent anemia. Nutritional interventions promote awareness about the importance of a balanced diet rich in iron, folate, and other essential nutrients. Menstrual health management, ensure access to affordable and hygienic sanitary products for adolescent girls. Strengthening healthcare services, improve access to quality healthcare services, particularly for reproductive health. Empowerment and gender equality. Promote gender equality and empowerment of adolescent girls through education, skill building programs, and awareness campaigning. Addressing child marriage. Implement and enforce laws and policies that prohibit child marriage, raise awareness about the harmful consequences of early marriage, and advocate for social change. Strengthening support system. Establish support system for adolescents, including counseling service, peer support groups, and community-based initiatives. Collaboration and partnership. Foster collaboration among government agencies, non-government organizations, community leaders, healthcare providers, educators, and other stakeholders. Together, they can pool resources, share best practices, and coordinate efforts of effectively address adolescence anemia and teenage pregnancy. By implementing these strategies and intervention, West Bengal can work towards minimize adolescence anemia and teenage pregnancy, promoting better health outcomes and empowering young individuals to make informed choices about their reproductive health. Now, my next slide is India's laws and policies regarding these issues. National Adolescence Health Program, Rashtriya Kishore Swasthya Curriculum, that have discussed by Dr. Krishnamurti early session. To these schemes, these programs to address the health needs of adolescents, including anemia and reproductive health. The Prohibition of Child Marriage Act. This law prohibits the solemnization of child marriages and imposes penalties on those involved in facilitating or promoting child marriages. The Act aims to prevent early marriage, which is closely associated with the early pregnancy. Integrated Child Development Scheme, that called ICDS. This scheme provides essential services for early childhood development, including supplementary nutrition, health checkups, and behavioral services. Next, the medical termination of pregnancy, that is called MTP Act 1971, introduced in 1971. This law ensures access to safe and legal abortion services for adolescent girls and women under certain circumstances. That is very much conditional. Right to Education Act 2009. The Right to Education Act mandates free and compulsory education for children aged 6 to 14 years. National Food Security Act 2013. This act aims to provide food security to vulnerable population, including pregnant and lactating women and children. Adolescents Friendly Health Services AFHS initiative. This initiative aims to establish and strengthen adolescents friendly health clinics and services across the country. Now the next slide is initiative that has been taken by the West Bengal government state. West Bengal has implemented various state policies and schemes to address adolescents, anemia, and early pregnancy. Here are some key initiatives in West Bengal. Shabala scheme, that is empowered women, aims to improve the nutritional and health status of adolescent girls in West Bengal. Under the scheme, girls aged 11 to 18 years receive financial assistance for improving their nutritional intake along with health checkups and health awareness programs. Adolescents health clinics. These clinics provide specialized services catering to the specific health needs of adolescents, including screening and management of anemia, reproductive health counseling, and family planning services. Weekly iron and folic acid supplementation program, WIFS. WIFS program in school to address anemia among adolescents. Iron and folic acid tablets are provided to school-going adolescent girls to improve their nutritional status and combat anemia. School health program. The program includes health checkups, health education and awareness campaigning to address anemia, reproductive health, and other health-related issues among students. Mother and Child Protection Program provides free maternal and child health services, antenatal care, institutional delivery, postnatal care, and transport facilities to pregnant women and newborns. These schemes aim to ensure timely and adequate health care for pregnant adolescents. Health and nutrition education. Emphasize health and nutrition education in school to raise awareness about anemia, reproductive health, and the consequences of early pregnancy. And lastly, Konyasri scheme, Girl Child scheme. This is a flagship conditional cash transfer scheme with the aim of empowering adolescent girls and preventing child marriage. And lastly, the intervention made by my organization provides all-round support to the children protection homes with special focus on proper balanced diet, educational needs, medical intervention and psychological interventions, vocational training to make them self-sufficient. Raising awareness and trainings among adolescents and community people. Rescue the children who are the victim of trafficking and child marriage. Conducts workshops on self-defense for the adolescent girls. Project includes trafficking victims, POXO children, special children, orphanage, old age homes, and other underprivileged people. Create opportunities for underprivileged but meritorious children in reaching heights and fulfilling their dreams. Supports other projects of underprivileged, cancer-affected, and leprosy-affected families. Thank you so much. Thank you all for your patient hearing. Thank you so much.
Thank you, Ms. Sunita Kar, for informing us about the pressing health issues of adolescents in Kolkata. I'm glad that on this platform we could see what are the different issues with the adolescents as well as the efforts that are being taken by your organization RF as well as the State Health and Welfare Department for addressing anemia and teenage pregnancy. So probably it's a long way to go, but I'm sure the steps are in the right direction. So thank you again for this nice presentation. Over to you, Professor Uday. Thank you.
Thank you very much. Yes, we had a fantastic session. So people have questions and comments, then now's your time. Just as a reminder, so we had Denny starting off reminding us about the different review types and showing us the evidence gap maps. And then we had Nimalaya talking to us about, reminding us about the need for dialogue and not monologue, and that voices really matter in our programming and how we work with communities, and that interventions need to be cost effective, and that a bottom up approach is cost effective and the best way to go. And then we had very practical experiences shared to us by Andani and Sunita. So thank you very much. That sets the theme for questions and comments. So if the floor is open, people want to raise their hands or they want to unmute. Or is it lunchtime? Well, for us, it's lunchtime. No questions, no comments.
I like to actually congratulate all the presenter. Very interesting part of the adolescents, such as radio program and about the indigenous adolescents, and also Sunita's and Andani's presentation. Excellent presentation for all the speaker. Thank you.
Yes, thank you. Agree completely. So, well done. Yes, here's one more hand here in our room. Right. Let me move.
Hi, everyone. My name is Christiane Wendler. I'm the technical director at Shout It Now. And I just wanted to ask, in looking at the presentations from Prof. Singhal, we see that we know young people aren't coming to clinics nearly at the rate that adults are. And it was I found it very interesting as well. And we found this in our work, is that menstrual issues and menstrual hygiene is a big need and concern for a lot of young women. And so again, from looking at this as a multi-sectoral approach, how do we, as community-based providers, how do we make sure we're working effectively with facilities to address menstrual health? And I particularly wanted to ask about the looking at the impact of being able to connect menstrual hygiene. And I found it interesting, the anemia, and being able to provide iron supplements for girls, and looking at how we can bring that in a community capacity as we engage on menstrual hygiene, how we can potentially bring in iron supplementation into community-based provision to address anemia in adolescent young women. Thank you.
Yes, thank you. So that sounds to me like a joint question to Andani and then Sunita. Andani, you want to start?
Okay, thank you, Prof. Ute. So basically, because as I presented that we have less adolescents utilizing the clinics, so I was not thinking of bringing it up in this platform, but we, like what you saw on my presentation, that we said that we need further investigations. So what is happening is that I am a peer in one of the protocols that has been approved already with the University of Pretoria, which we are going now to go to the community, which we are working with the adolescents. So we don't want now to assume why they are not going to the clinics, because maybe they are afraid, because they're afraid to go and be seen attending clinics. So now we are doing research where we are going to evaluate, work with adolescents themselves to recruit other adolescents, so that we can start now engaging with them to understand what is the issue of not using the clinics. And now this will be like a participatory research where we now talk to them face to face and understand what is the most what is the difficulty for them to attend clinics. Now, as you saw in my presentation, we have a center that we have identified in Atteridgeville, which is, it's not a clinic, but it's like a laboratory, what I've said, which is going to be based in Lerauting Hospice, where we are going to recruit those adolescents to come and do some focus groups there, where we have to engage with them and tell us more what are the issues, what are the challenges of them in those communities, and to understand their needs. And now we have to provide in the way that they want it to be addressed, not us assuming that this is that they want. They need us to go and mobilize and just talk to them, because if you understand, if you realize, there's a lot of fatigues in the community for people just going there and ask them questions and just leave them just like that. But now we're trying to now give them proper solutions, but to work with them for them to give us what the real need is for them to us, for us to help them, to assist them. If needs be for us to open a center, I think that will be a proper thing that we need to start doing. Thank you.
Yes, thank you very much. Reminding us of the motto, nothing about us without us. Yes, so the bottom-up approach is obviously coming out again here. Sunita, do you have a comment on this question?
Actually, we have conducting several programs and projects with the adolescent girls in Kolkata and other district in West Bengal. So day to day, we have interacted with them, and we have there are several challenges, and really health issues is a big issues there. Though adolescents are very eager to take their health care and day-to-day life, their challenges, face the challenges, but somehow they need the guidance, they need empowerment, that we are trying to do that with we are making a group and leadership training programs, such empowerment program, rights program, where day to day we are teaching them, and they are taking down the leadership of their community. Thank you.
Yes, thank you very much. So, I mean, it's absolutely fascinating. We are a few thousand kilometers apart, and we have similar problems and similar solutions, actually. So that's great. I think that's really, today was really good for that, in terms of, reminding us that we are all human beings somewhere on this planet, trying to make to better the world, also for our future generation, which we are, the adolescents and the children are the future generation, and we need to obviously take care of them and the planets that we are living on, so that they also still have a good world to stay on. So that brings this session to an end. I'm reminded to ask you to please fill in the evaluation form. The link to the form has been posted in the comments. Is there anything else? Okay, so the request is, before we now going to hand over to our last speaker to close the session, but can everybody please put on their videos so that we can take a photograph of everybody who's in the session. So now's your time to shine. Yes, no, people are hearing me clearly because they are. Yes, we are looking, that's looking great. We need to fill this little puzzle here for ourselves. We're just going to give everybody a minute or two to find that video button and to think that I combed my hair this morning. Are there more videos coming? Do we have some shy people on the group? I think that's what you're getting, Professor. Can we take a, did you take your photo, your screenshot? Right, the screenshot's coming. Time to smile now. Okay, all good. Okay, thank you. So that was the last session. I'm going to hand over to Dr. Paramita Bhattacharya. Oh gosh, I'm sorry, Paramita. I can't read my own handwriting now. Yeah, so he's the assistant director at CPHR and is trained in economics, something I don't know so much about. Over to you for the closing remarks. Thank you.
Thank you so much, Professor Ukte. So we had just a moment. I hope it's clear now. So thank you for such an enlightening session. We've had such eminent speakers speaking on the adolescent health in both South Africa and India. Then we had Dr. Denny speaking about the evidence-based healthcare system, and some we also got to know about the grassroots realities from the case studies. So it was overall a very enlightening session. And what we could identify from here is the commonness of the problems in South Africa and India, where the socio-economic factors are attributing towards the adolescent health problems that we could get from the speakers. And what we could see is that there is a vicious circle in operation, where we can see that due to poor socioeconomic conditions, we are getting poor adolescent health, and it will lead to low productivity, and then it will again lead to poor economic conditions. Thus, it's a vicious circle in operation. So the whole objective is to turn it into a virtuous circle. And I think that was the sole objective of this workshop, to how we can make it a virtuous circle. So basically here is where the evidence synthesis and evidence implementation comes to play an important role. And as Dr. Denny also showed us, how we can use the evidence gap map, tools like evidence gap map, to identify the gaps and systematically conduct primary studies as well as systematic evidence synthesis to systematically use the generated evidence for suitable policy making, for suitable policy level intervention. So that's the entire purpose. So that's what we could get from this entire session, and that was the sole objective of this workshop, as to how we can use the entire information that is available, the entire information. We could see that there is a commonness in South Africa, India, and maybe many more LMICs also. We will find the same things there. So we have to utilize this information in a systematic way using the evidence synthesis tools to generate the information and use it for proper policy making purposes. So that's the main objective. And finally, I would like to conclude this session by thanking all the chairs and the chairperson. I would like to take the opportunity to thank Dr. Debashish Basu, Dr. Ben Monteodi, Dr. Nirmalya Mukherjee, Professor Ekta and Professor Ute for chairing our sessions, and also thank all the speakers, Dr. Goen Ramakoppa, Dr. Jayati, Dr. Krishnamurthy, Dr. Denny John, Dr. Nirmalya Mukherjee, Mr. Andani Singho, and Ms. Sunita Kar. Thank you so much for giving us glimpses of South Africa, India, grassroots realities, importance of community interventions, and a special thanks to Dr. Debashish Basu for conceiving the idea of this joint workshop, and also Dr. Jayati for continuously coordinating with all of us and make this event a reality. So a special thank you to ma'am for all the painstaking exercise in coordinating the activities and making this event a reality. And thank you so much for the enormous efforts put in by the entire JBI team of JBI Equilini and JBI CPHR month. So a big thank you to the entire team. And definitely it would not have been possible without the JBI technical support. The JBI has continuously technically supported us to carry out this event successfully. And finally, I would like to thank our audience for participating and attending this program.